بسم الله الرحمن الرحيم. أعزائي طلاب المرحلة الرابعة في كلية الطب جامعة ميسان، السلام عليكم ورحمة الله وبركاته. This video lecture about neck surgery. In this lecture, we will talk about the common diseases that affect the neck, surgical diseases, and the common swellings that present in the neck. We will start with the Ludwig's angina. Ludwig's is the name of the physician that described this disease. So Ludwig's angina, it is a life-threatening, rapidly progressive gangrenous cellulitis of the soft tissue involving neck and floor of the mouth. So keep in your mind that it is a life-threatening condition. It causes diffuse swelling and browny edema of the submandibular region. So the characteristic feature is the browny edema in the submandibular region. Usually it starts in the submandibular region. It is common in severely ill and in advanced malignancy, causing trismus, that means spasm of the facial muscle, and laryngeal edema. That's why it is life-threatening. Extension of infection into parapharyngeal space may lead to dreaded internal jugular vein thrombosis, which also is life-threatening. As the infection is deep to deep fascia in a closed facial plane, it spreads very fast, causing dangerous complications. So one of the risks is that it's rapid spread. The precipitating factors of Ludwig's angina include caries teeth, oral or other malignancy of oral cavities, submandibular salivary infection or calculi, chemotherapy, chronic diseases like diabetes mellitus, cachexia of any cause. About the clinical features of Ludwig's angina, there's fever, the patient looks toxic, and there is diffuse swelling at the region affected, dysphagia, trismus. Also, what is characteristic is intraoral edema, which is common, and browny swelling in submandibular region. A browny is strong edema. Also, there is putrid halitosis. Halitosis, bad smell from the mouth. Putrid halitosis. Treatment of this condition starts with antibiotics and IV fluid, and then surgery in form of decompression. This is the Ludwig's angina patient. Patient is affected with Ludwig's angina. You can see here there is severe swelling, diffuse swelling with a browny edema with features of infection, and then it is treated by surgery by this incision. Incision should be done, which should be deep incision extended into deep fascia and also cutting both mylohyoid muscle. Complications of this condition include laryngeal edema and respiratory distress, may require tracheostomy, septicemia, extension of infection into parapharyngeal spaces. Another pathology, which is common pathology, is cervical tuberculous lymphadenitis. The causative organism here is Mycobacterium tuberculosis, not Mycobacterium bovis. The site usually it is common in neck lymph nodes, common in upper deep cervical lymph nodes, jugulodigastric, more than 50% of the cases in jugulodigastric lymph node. Next common site is posterior triangle, about 22%. Disease can also occur in other lymph nodes in the body, like axillary, lymph nodes, para-aortic lymph nodes, mesenteric lymph nodes, inguinal lymph nodes. And the disease may be associated with HIV infection and lymphomas. What about stages of tuberculous lymphadenitis? This diagram and this picture describe the stages of tuberculous lymphadenitis. Stage 1, stage of infection of adenitis. This is the lymph node, and this is the deep fascia here, and this is subcutaneous tissue, and this is the skin. So stage 1 is stage of infection and lymphadenitis. Stage 2 is stage of periadenitis with matting, التصاق الغدد الليمفاوية. Stage of periadenitis and matting. Stage 3 is a stage of caseating necrosis. Here, start the caseatic necrosis with cold abscess formation. Stage 4, stage of formation of collar stud abscess. collar stud الياخ اللي يلبسونها الموسيقيين عادة، يعني شايفينها الياخ الصغيرة، الرباط يعني بدل الرباط، فيكون بجزئين، هذا جزء وهذا جزء، يسمونه collar stud abscess. Stage 5 is a stage of formation of sinus. The abscess perforates through the skin and then creates sinus with discharged yellowish caseating material. Often fibrosis and calcification can occur with or without treatment. In the gross pathology, there will be firm matted lymph nodes with cut sections show yellowish caseating material. We say there is a caseative necrosis. Microscopically, there is epithelioid cells with caseating material that are seen along with Langerhans types of giant cell. Langerhans type of giant cell. These are epithelioid cells that unite together, and it is a giant cell with multiple nuclei. Clinical features. There is swelling in the neck, which is firm, matted, and there may be cold abscess, which is soft, smooth, non-tender, fluctuant, without involvement of skin. It is not warm. There is no overt features of inflammation, so it's called cold abscess. As a result of increased pressure, cold abscess rupture out of the deep fascia to form collar stud abscess, which is adherent to the overlying skin. Once collar stud abscess bursts open, discharging sinus is formed. Tonsil may be studied with a tubercle. Associated pulmonary TB should also be looked for, and also cervical spine is examined for tuberculosis. Once you find TB in any site, you have to think about the TB in the common sites. And the differential diagnosis, you can see here, it is tuberculous lymphadenitis, and it is just about to rupture, to form a sinus. The differential diagnosis of cervical lymphadenitis. First, non-specific lymphadenitis. Lymphadenitis due to any other cause, not TB. Lymphomas, chronic lymphatic leukemia, secondaries in the neck. Bronchial cyst may mimic cold abscess. Lymphatic cyst mimics also cold abscess. HIV with lymph node involvement, also in differential diagnosis of cervical tuberculous lymphadenitis. Discharging sinus, also in the differential, discharging sinus due to actinomycosis, also in the differential diagnosis of cervical tuberculous lymphadenitis. You can see in this patient, there is multiple cervical lymphadenopathy, but this is due to lymphoma. And this is cervical lymphadenopathy here, but due to malignant secondaries. The required investigation, like any investigation for TB, hematocrit and ESR, usually there is raised high ESR, fine needle aspiration cytology of lymph node, and smear for acid-fast bacilli from the tonsil, and culture. Also smear from the discharging sinus and culture. HIV test, ELISA and Western blot, because as we said, it may be associated with HIV and in differential diagnosis of HIV. Open biopsy when fine needle aspiration cytology is inconclusive. Chest X-ray to exclude pulmonary TB, and the most recent investigation is BSR is very useful. Treatment of cervical tuberculous lymphadenitis, antitubercular drug, usually for 6 to 9 months. Aspiration, if there is cholesterol abscess or there is cold abscess. Incision and drainage, if there is no resolution on aspiration. Surgical removal, sometime indicated, and the indication for surgical removal of tubercular lymph node when there is no local response to drugs or when sinus persists. Usually excision of the sinus tract is required in tuberculous lymphadenitis associated with sinus. Now, I will talk about the one of complication of tuberculous cervical lymphadenitis is called abscess. Deep to deep fascia. So it is deep to deep fascia. Once it perforates deep fascia, it becomes cholesterol abscess. No evidence of signs of inflammation. So that's why we called it cold abscess. Not warm, not tender, like any other classical inflammation. It is a smooth, soft fluctuant, non-transient. It is not adherent to skin and no redness. Contains cheesy caseating material. It may form cholesterol abscess and then sinus. This is a patient with cholesterol abscess. You can see here this swelling is cholesterol abscess. No feature of inflammation, no features of inflammation. And this is a sinus in an earlier biopsy scar. This is aspirated cold abscess. You can see here, this is aspirated cold abscess, sent for culture and sensitivity and direct examination. The required investigation, fine needle aspiration cytology, and also investigation for acid-fast bacilli in the abscess. Also, the abscess should be sent for culture and sensitivity. Differential diagnosis from branchial cyst and from lymphatic cyst. A treatment by antituberculous drug and what we call zigzag aspiration. We should not aspirate directly, push the needle directly into the abscess cavity because it will induce or will complicated by sinus formation. It should make the needle its way to the abscess cavity in zigzag way. And the drainage using non-dependent incision. Usually when we drain any abscess, it is preferable to put your incision in the dependent part. dependent يعني أكثر شيء يتأثر بالجاذبية الأرضية مثل ما يقول، أقرب شيء على الجاذبية الأرضية حتى يصير الدرينج better. هنا we avoid drainage independent because if we drain independent, this will encourage the formation of sinus. So we drain in cold abscess in non-dependent area. Now I will talk about one of also common pathologies that affect the neck is bronchial cyst and fistula. Before we start to talk about this, we will start about the embryology in the neck. In embryo, the neck starts to develop between the head and the developing heart. And during this development, there will be 5 ridges develop on each side of the neck called bronchial arches. يعني الرجز اللي هي مثل ما نقول حافة أو علوة خلينا نوصفها. هاي الرجز بهالطريقة هاي 5 رجز 1 2 3 4 5 من كل جهة 5 رجز. هاي يسمونها البرانكيال arches. The first arch اللي هو هنا هذا first arch form mandible and ear. هاي first arch من عنده راح يطلع لنا الماندبل والاير. The second arch forms the hyoid bone. هذا second arch forms the hyoid bone. Third arch forms the neck over the thyroid region. The third arch هذا هو اللي راح from it derive the structure in the neck over the thyroid region. During embryological development,